Gentlemen, good afternoon, colleagues. I want to formally welcome you to the second session for this year of the Pediatricians in Private Practice meeting. Today, we'll have a very young dynamic consultant talk to us about insulin therapy in diabetic ketoacidosis in children. She trained at LASUT and also did her subspecialization at Lagos University Teaching Hospital under Professor Oduwole, who incidentally is our moderator for today. So without much ado, I'll hand over to the chairman of this group, Dr. Femi Mobalaji Lawal, for his opening remarks. Over to you, sir.
Okay, thank you very much, Sandy. Just for me to welcome everyone again. In particular, I'd like to recognize our respected elder, Dr. Ame Idoko, who was one of the first people to join today. So I welcome everyone, and I look forward to a very stimulating conversation. So I'd like to hand over back to Dr. Eletu at this point.
Okay, thank you very much, sir. The chair or the moderator for today is our big sister and our good friend, Professor Oduwole. So, Prof, I hand over to you. Thank you very much. Professor Oduwole, you have the mic.
I didn't know I was muted, sorry. Let me start all over again. Good afternoon, everybody. It's nice to be here. And I'm so happy to moderate this particular session today on diabetic ketoacidosis. Anybody who knows me that diabetes is one of my love. And I am sure Dr. Akinola is going to practice with the program today. Diabetes ketoacidosis management is something that most people are really afraid of taking care of, and we quite understand it. But as endocrinologists, we've always wanted people to be able to start off, even if they have to still refer to us. Whatever you do, make a big difference in the outcome of the child. So without much ado, I will hand over to Dr. Akinola, who will take us through DKA management. How do we use our insulin? Thank you.
Thank you very much, Ma. Good afternoon, the chairman. Thank you. Good afternoon, Dr. Eletu, respected elders, and the house. Thank you very much. It gives me great pleasure to talk to you a little bit about the management of diabetic ketoacidosis. Previously, we used to think that a lot of our children didn't have diabetes, but we are coming to realize that the true picture is that indeed diabetes is with us, particularly type 1 diabetes in children is with us, and that before now they have somehow been underdiagnosed. We have missed those diagnoses in them. And we do know that one of the leading complications that is a cause of morbidity and mortality in these children is diabetic ketoacidosis. So for that reason, we want to talk a little bit more about diabetic ketoacidosis. The emphasis on this talk really is about the subcutaneous insulin therapy. So that's where the emphasis is. We will take a preview, if you like, of the management of diabetic ketoacidosis. We'll talk a little bit about each section, but we will focus on subcutaneous insulin therapy in diabetic ketoacidosis. So diabetic ketoacidosis is the commonest complication that is encountered in type 1 diabetes globally, not just in our part of the world, but indeed globally. And it is a state of acute decompensation. This decompensation is as a result of insulin deficiency, or sometimes insulin resistance. So as we know, diabetic ketoacidosis occurs predominantly in children with type 1 diabetes, but it has also been reported to occur in type 2 diabetes, whether it is in children or in adults. So the cause is as a result of the severe insulin deficiency. And usually in diabetic ketoacidosis, there's a combination of metabolic changes going on. So there's hyperglycemia, there's ketosis, and then there's metabolic acidosis. So this slide gives us a picture of the pathogenesis of diabetic ketoacidosis. So I want us to look a little bit to the left, to focus more on the left side of the slide. And we have talked about absolute and sometimes relative insulin deficiency. So the body exists in a dynamic, hemodynamic state. And so there's a balance of insulin on one hand and the counter-regulatory hormones on the other hand. So these counter-regulatory hormones are mainly the growth hormone, cortisol, and epinephrine. So they exist in a balance. Once there's deficiency of insulin, that means that there is now a predominance of counter-regulatory hormones. Okay, so we'll come back to that in a minute. And what the defect in insulin does, this insulin deficiency, let's start by what does insulin do? So one of the first things I learned under Professor Oduwole's tutelage is to look at insulin as a key that opens the door of the body cells to glucose, which they actually need and use as a metabolic fuel. So if insulin is missing in action, the glucose is not able to enter the cells. And so the body generally reads that as a state of glucose deficiency. Meanwhile, there's an accumulation of the glucose in the body cell. So that's why there is the hyperglycemia. In order to counteract the effect of this deficiency of glucose within the body cells, the body now starts to break down other sources to produce or to provide an alternative metabolic pathway for the body. So there is fat breakdown, there's lipolysis, glycogen is also broken down, and then the process of gluconeogenesis, all in a bid to make alternate sources of fuel as well as glucose available to the body. Now, there are byproducts of this, and what the important byproducts here are the ketone bodies, the acetone, the acetoacetate, as well as the beta-hydroxybutyrate. And these ketone bodies are acidic. So as they build up, the acidity of the body builds up as well. So there is ketosis, and in addition to the ketosis, there is also metabolic acidosis. So that gives an idea of why absolute insulin deficiency will result in the triad of hyperglycemia and ketosis, as well as metabolic acidosis. Now, these counter-regulatory hormones also add to it. What do? They further break down other sources of metabolic fuel. And so the result is that they increase the glucose level of the body. So that worsens the hyperglycemia. And so that forms a framework of what is going on, what exactly is going on in diabetic ketoacidosis. Now, if this process is not arrested by providing insulin, it gets progressively worsened and then can lead to death if nothing is still done. So what are these clinical features of diabetic ketoacidosis? We will see that on the next slide. So diabetic ketoacidosis may present with features of a precipitating infection. And if it presents, as usually it does with the younger children, so children who are younger than 5 may present with an infection. And a doctor who is not thinking of the diabetes or diabetic ketoacidosis may often miss it. So I give the example of one of the youngest patients I managed, a 14-month-old, who presented with what looked like septicemia. And so for the first 2 days, he was treated as a case of septicemia until somebody just decided to do a random blood glucose check. And that gave away the fact that there was hyperglycemia. So one thing led to the other, and because there was a hyperglycemia, then this suspicion of diabetic ketoacidosis rose. And when other investigations were carried out, we found out that truly this 14-month-old had diabetic ketoacidosis. There are many other children that are in that category, but have been missed because people focused more on the infection and did not think that there was a background incident precipitating this infection. I give another example of another child, still less than 5 years, and this child had diabetic ketoacidosis, but had presented in the emergency room with clinical features of a bronchopneumonia. So at the time, the bronchopneumonia was thought to be mild to moderate, and so there was no indication, or so the doctor thought, of admitting. And so this young child was discharged home, only to return a few days later with again what looked like a worsening bronchopneumonia. And still at the time, and for many days, we still thought that the child had bronchopneumonia. And when eventually a history, a more thorough history was taken, we realized, in fact, that this child had polyuria, polyphagia, polydipsia, had been losing weight, and then that led to the suspicion of a diabetic ketoacidosis. So that was my first experience with diabetic ketoacidosis. I will return to that story in a little bit. So the other features of diabetic ketoacidosis are altered sensorium. So it's not always frank coma. It could be an altered sensorium. And actually, in some cases, we actually have patients who walk in, they're conscious, they're alert, they're talking rationally, they're answering questions appropriately. And so again, in such patients, the diagnosis of DKA may actually be missed. Cosmal respiration is described as deep, rapid, and labored breathing. And this is another clinical feature of diabetic ketoacidosis. And the reason for this is that we talked previously about the accumulation of the metabolites, the metabolic acidosis. So the body tries to get rid of the excessive acid, and so compensates by the deep, labored, fast breathing that we describe as cosmal respiration. The fruity breath odor is as a result of the ketones, which we have named before as the acetone, the acetoacetate, and the beta hydroxybutyrate. So they are responsible for the fruity breath odor. Not everyone has that keen sense of smell to be able to identify a fruity body odor. So not to worry, there are other clinical features that still point to diabetic ketoacidosis. So a child who has DKA can have anorexia, nausea, sometimes they even vomit and have abdominal pain. And this group of features, again, as a result of the ketones, the ketones. So another prominent feature of DKA is dehydration. And in many cases, we say that once there's DKA, assume that there's severe dehydration already, because the decompensation has already been going on even before the child presented with DKA, but got worse, okay? So we usually assume that there's severe dehydration in diabetic ketoacidosis. And one of the many ways to identify a child who is severely dehydrated is having a decreased skin total. So all of these clinical features occur against a background of previous weight loss, polyuria, polydipsia, and polyphagia. So we say that typically it's not difficult to identify diabetes if we ask these 3 P's: polyuria, polydipsia, polyphagia, and the previous unintentional weight loss. The next slide just shows in picture what we have taken time to describe in the clinical features. So we understand why there is hyperglycemia, and because there is hyperglycemia, the body will also wants to compensate for that, because the hypothalamus senses that the osmolality is high, and so there's a sensation of wanting to drink more, excessive thirst, and that actually leads to the polydipsia. Okay, so the polyuria, hyperglycemia, glucose, and then the renal threshold for the glucose is exceeded. So glucose is lost in urine, and we know that water usually follows that osmotic gradient. So that is why there is excessive urination. And sometimes a child who has previously been continent now ends up having diuresis and nocturia. So we also say that if there's nocturia in a child who has been previously continent, we should think diabetes. So all the other features we have explained. So how do we make a diagnosis of DKA? On the next slide, to make a diagnosis of DKA, 3 factors must be fulfilled. And according to the guidelines that were put out by the International Society of Pediatrics and Adolescent Diabetes in 2018, these 3 factors must be present. So first, there must be hyperglycemia that is equal to exceed 200 milligrams per cl, or the equivalent of 11 millimoles per liter. And there must be a metabolic acidosis, which we can measure by doing a venous pH, which will come, whose results will then be less than 7.3, or the one that is more available to many of us in our setting, serum bicarbonate. So the serum bicarbonate is less than 15 milliequivalents per liter. And the third factor is evidence of ketosis. So there must be ketone bodies in the blood or in the urine. And we have taken time to explain all of this in the previous slide. So let's talk about the principles of management of DKA. We call them principles because they are principles, and what we work with are guidelines. But again, as in many other cases, every child's care must be individualized against this background of the principles of DKA management. So if a child with DKA presents a shock, the first thing is to correct the shock, as we would for other children that present with hypovolemic shock from other causes. And this is done with intravenous fluid, normal saline at 20 mils per kg. So if a child is in shock, we want to give that over a short period of time. If the child is in shock, usually between 20 and 30 minutes. But if the child is an infant, then we correct the shock more slowly. And then in that case, we can correct it over 1 hour. However, if the child is not in shock, then we start to correct the severe dehydration. And then we start with the bolus of 10 to 20 mils per kg, also using normal saline in the first hour. Now, once this has been done over 1 hour, then it's time to reassess the child. If by that reassessment, the child is still adjudged to be in severely dehydrated, then again, the fluid can be repeated over another hour. Okay, over another hour. So in as much as we want to correct the dehydration, we don't want to do it too quickly. We want to do it over the course of 48 hours, 48 to 72 hours. But we calculate the child's fluid requirement over the period of 48 hours. And what that means is that we'll calculate the maintenance of that child over the 2 days, and then we add it to the correction of the severe dehydration. We add all of it together, and then we give it evenly over 48 hours. Of course, we must subtract, when we have made this calculation, we must subtract what we have given the child in terms of the first bolus, and if we have given the second bolus, we must remember to subtract. Whatever the remainder is, we now give it evenly over the course of 48 hours. So that's how we take care of the dehydration. Now there is also electrolyte derangement that is occurring in DKA, and in particular potassium. The serum potassium may be normal, it may be high, it may be low, all because there are fluid shifts and the cations, anions, they are crossing from the intracellular to the extracellular space. So even though a child may have a high serum potassium, for example, we should still remember that in a child with TKA, there's a total body deficit of potassium, because potassium a lot of potassium has been lost in the urine previously. So correction of potassium is the potassium chloride, which is usually put in the IV fluids at a dose of 20 to 40 milliequivalents per liter. So that's how to take care of the potassium deficit in that case. Correction of the hyperglycemia is done with insulin, which we will talk about in a little bit. Correction of acidosis is also done with insulin. And as we said before, many children with DKA may present with features of an infection. So we should screen for an infection. And if the child has an infection, then that child should be treated with antibiotics. And if the child has malaria, then the malaria should also be treated. We usually place a lot of emphasis on preventing this complication of cerebral edema, which is why the fluid correction, the dehydration, is done slowly over 48 hours, so that we don't tip the child into a complication of cerebral edema. However, if cerebral edema occurs, then cerebral edema is an emergency that needs to be addressed immediately. So these are generally the principles of managing diabetic ketoacidosis. Next slide. So on this slide, there are two figures or two pictures in the same slide. Now, the slide to the left shows, this is my story, this is the way I want to tell it, that the picture to the left shows a child who is unhappy and has two intravenous lines going on at the same time. Now, this is the picture that typically we would have in any child with diabetic ketoacidosis. We would usually put up two lines. One would be to deliver insulin, of course, with a fluid, usually normal saline. So the insulin is put in normal saline and is delivered by one intravenous line. The second intravenous line is typically put in place so that it will take care of the fluid requirement, the dehydration, and then the maintenance over the course of 48 hours, because our aim is to get the child out of DKA within 48 hours. So that's the reason for having those two lines. But this picture is gradually changing to the one on the right, where this child has only one line, intravenous line, and that intravenous line is to correct the dehydration and to give the maintenance over the 48 hours. The insulin will be delivered subcutaneously. Next slide. Next slide. So this picture shows, on this picture, we see that subcutaneous insulin is being delivered. And so the subcutaneous insulin, whether it's being drawn into an insulin syringe from an insulin vial, or whether the what is used is the more, the insulin pen, which is widely available now, and which is simpler, less painful to use, though more expensive than the vial. And the last set of pictures on the slide shows an insulin pump. All of them are various ways of delivering insulin. So that's what this picture is about. And remember that the focus now is on subcutaneous insulin therapy in DKA. So let's see what other people have done in other studies that they have shared. So on the next slide, there are two studies that have been summarized on this next slide. On the one to the left, it summarizes a randomized prospective trial in Brazil that was published in 2005. And what the researchers did was to study 60 DKA episodes. Now, 30 of those DKA episodes were treated with subcutaneous insulin, and the other 30 were treated with continuous intravenous regular insulin. So these two groups were studied and they were compared. And in both groups, the blood glucose level reached 13.8 millimoles per liter, which is about 250 milligrams per deciliter in about 6 hours. And they continued to give the insulin and realized that in about 12 hours, there was a resolution of metabolic acidosis in the group that had subcutaneous insulin given. But in the other group that had regular insulin, the metabolic acidosis resolved in about 6 hours. So that's a summary of the Brazil study. Now, the Israel study, which was published in 2017, looked at 76 observations. They looked at some newly diagnosed, in addition to the known type 1 patients, children with type 1 diabetes mellitus. In this group, they were all treated with regular insulin. And they realized that the resolution of diabetic ketoacidosis took about 12.8 hours in the new patients, and then about 9.5 hours in the patients who had previously been diagnosed with diabetic acidosis. I'll just make a reference again to say that usually many children present for the first time with diabetic ketoacidosis. And it is when that diabetic ketoacidosis is diagnosed that people actually know that there has been an underlying type 1 diabetes usually. Okay, so that's the background. So what this slide tells us that whether they were given regular insulin or whether they were given the other forms of, that's whether they had intravenous insulin or they had subcutaneous insulin, they also had a resolution of metabolic acidosis in about 12 hours. So that's a summary that in all of them had a resolution of metabolic acidosis in about 12 hours. Okay, so I want to share on the next slide my experience in LASO. You remember that I referred to a child who had come in with a mild to moderate episode of bronchopneumonia and who later came in with severe bronchopneumonia. And I said that was the first encounter I had with DKA as a young resident. I will share this story because I'm sure that the late Professor Budikpe, God rest his soul, would like me to share it. So when we made this diagnosis, we made the diagnosis a few hours before the child died. And I was very sad, and I expressed to him how sad I was, as most of us usually are, and all of us usually are when we lose patients. And he told me that if these were his words, and he said, if you feel bad, can you imagine how bad I feel? Because I was the first person who saw the child in the emergency room and asked that the child be treated on an outpatient basis for mild to moderate bronchopneumonia. I've shared this story to say that if we're not looking out for diabetes, we may often miss it. So this child had diabetes, which was not diagnosed, and then had this acute complication, decompensation state of DKA, which was not diagnosed until it was too late for that child. So we lost that child in LASO because there was a delay in making the right diagnosis. We eventually made the diagnosis, but it was too late to help the child. And when eventually we were able to make the diagnosis, we didn't have the expertise. We didn't have, by then we had a short time and we didn't even quite know what to do. Whatever it was we did was not adequate to care for the child. So subsequently, we had other children who had a relatively earlier diagnosis, but still the patients died because still we hadn't got the hang. We hadn't got the expertise of managing children with diabetes. So in continuing the story, over time, the expertise came in the form of a training at the PESPA Center in Luke. And after that, we're able to make diagnosis of DKA on time. And our mode of addressing the hyperglycemia and the acidosis was to give intravenous insulin. So many of the children, in fact, all of them at the time, were getting intravenous insulin until we learned again that we could actually use subcutaneous insulin in mild to moderate cases of diabetic ketoacidosis. And with that, that's what we have practiced in the last 6 months. And we have been able to successfully manage patients with mild to moderate DKA in the last 6 to 7 months. So what is it that we did? On the next slide. So when do we actually use subcutaneous insulin in the management of DKA? When the DKA is mild to moderate. And what are the advantages of the subcutaneous insulin? The advantage is that the subcutaneous access is easy. It's not as difficult as the intravenous access, so it's easy to use, and it doesn't quite require a rigorous monitoring. In giving intravenous insulin, one has to monitor well because usually it's given through a infusion pump, or many times as we do, we just give them through the line, and the insulin is running along with intravenous fluid from the bag. And we have to be sure that the calculated drops per minute is what the child gets. So all of this takes rigorous monitoring that subcutaneous insulin does not require. More so, as I have shown in the previous studies, so even subcutaneous insulin in DK is a valid alternative to the previously standard intravenous insulin therapy that we have known. Also, when diabetes expertise is not immediately available and manpower is insufficient to accommodate the kind of monitoring that I have described, then subcutaneous insulin is indicated. I have advocated, or I am advocating the use of subcutaneous insulin in DKA, but I want to emphasize that this is for mild to moderate cases. And when the cases are severe, then ideally they should be managed in an intensive care unit. I hear you, because in many of our centers, we don't have intensive care units, but then that's the standard. So that's what should be done. The next slide. So having emphasized the severity of DKA, how are we able to separate mild from moderate and then severe cases? So we use the venous pH or the serum bicarbonate, which many of us are able to do across centers. So any bicarbonate that is less than 5 is severe DKA. If the bicarbonate is between 5 and 9, then it is moderate. And if it is between 10 and 15, then we classify that as mild. So the severity of DKA can be judged with the level of the serum bicarbonate. Next slide. So having talked about the use of subcutaneous insulin in DKA, the next question to answer is which insulin should be used, because there are various kinds of insulin and not all of them are acceptable and indeed can be used in DKA. So the insulin that we can use are regular insulin or the short-acting analog. So for the regular insulin, I give an example of Actrapid, and the dose for regular insulin is 0.8 units per kg, which is given, that's a daily dose, but we're going to give it 4 hourly, which means that we will give it in 6 doses. So I give an example of a child that weighs 30 kg, okay? So the dose for the child for that day is 30 multiplied by 0.8, which will give us 24 units. That 24 units should be spread across the day. And since we have seen that it's giving 4 hourly, then we divide it by 6. And what it means is that 30 kg child will receive, that child that weighs 30 kilograms will receive 4 units 6 times in the course of the day. And then this is continued until DKA resolves. So DKA is considered to be resolved when the bicarbonate at least 50 millimoles per liter. Now, when remember that before we start giving insulin, or I should say that before we start giving insulin, then the child should have been rehydrated. In talking about the principles, I talked about giving the first bolus and reassessment. So at the point of making a reassessment, one can give, and one should start to give insulin after that first hour. In other words, the appropriate time to give insulin is in the second hour after rehydrating to that 10 to 20 mils per kg in the first hour. If, however, at reassessment, the child is still judged to be dehydrated, then subcutaneous therapy at that point in time may not be the best. So at that point, we can actually use the intramuscular route, which is more painful, but that way we're certain that the distribution of insulin is adequate until the child is properly rehydrated, and then we can switch to the subcutaneous route. So we can use regular insulin. So you ask, what if regular insulin is not available? Next slide, please. So if regular insulin is not available, we can also use rapid-acting insulin analogs. So examples of that are insulin aspart, which is available as Novorapid, Lispro, which is available as Humalog, and Glulicin, which is available as Apidra. For all three of them, the doses are the same, and they differ from the regular or soluble insulin that I described earlier. So the dose for the rapid-acting insulin analog is 0.15 units per kg, and this is given every 2 hours. Again, it's given every 2 hours until DKA resolves. However, if the blood glucose is coming down at a rapid rate, I will discuss that a little bit later, then we can actually reduce this dose from 0.15 units per kg to 0.1 units per kg, still giving every 2 hours. So a child that weighs 20 kg will have 20 multiplied by 0.15. That comes to 3 units of any one of these rapid-acting insulin analogs that are available. And in accordance with the blood glucose reading, we can titrate stepwise, either downwards or upwards within about 10 to 20%. So regular insulin can be used subcutaneously in DKA management, and if regular insulin is not available, then we can use the rapid-acting insulin analog like Novorapid, Apidra, Humalog. Next slide. So in discussing all of this, there are just a few points that I would like us to note. I'm wrapping up now. So the few points I would like us to note is that every center should have a protocol for the management of DKA, so that it's not at the point where a child comes, the diagnosis is made, and pandemonium, everybody starts to run up and down, because usually DKA is dramatic, has a dramatic presentation in children. So we want to be ready with a protocol for management. And the other message I want to pass across and emphasize it, I haven't done that previously, is that these subcutaneous insulin administrations are indicated for mild to moderate DKA. And even though I have focused on subcutaneous insulin therapy, that is not to say that the other part of the management of DKA as a whole should be jettisoned, not at all. So vital signs should still be monitored regularly, electrolytes, urea and creatinine, blood glucose every hour. At least blood glucose every hour for the first 12 hours or so, until the blood glucose improves, and then we can space it out a bit more. Blood gases in centers where blood gases are available. I alluded to coming back to this next point a little later. And yes, even though there's hyperglycemia, we don't want the hyperglycemia to normalize too quickly. So we want it to reduce gradually by about 90 milligrams per cl every hour, or less than 5 millimoles per liter every hour, because we want to prevent cerebral edema from happening. And the ultimate aim, even as we try to correct the hyperglycemia in DKA, is to keep the glucose level between 100 milligrams per cl and 180 milligrams per cl. It is also important to determine the cause of DKA, and this we can do by asking appropriate questions and then counseling appropriately, so that we can prevent future episodes of DKA occurring in the same patient. So in all of this, as I wrap up, my take-home message on the next slide is that subcutaneous route of delivering insulin is easy to access, and it is effective, especially in mild to moderate DKA. And indeed, because it is effective, is as effective as has been shown in previous studies as giving intravenous insulin. So we should routinely use it in resource poor settings like ours. But we should remember that in children who have impaired peripheral circulation, then the intramuscular access can't be used until the circulation improves. And finally, children with DKA, and indeed all children with diabetes, should be managed in collaboration with a pediatric endocrinologist or a diabetologist or an experienced colleague. So I lay emphasis on all of this, particularly with reference to DKA, because even though we may have guidelines, they are really guidelines, and expertise is necessary to be able to successfully manage DKA and indeed children with diabetes. So I thank you all for listening.
Thank you, Dr. Akinola. You've really done well. DKA is not an easy subject to discuss, especially when you want to bring it down to the level that everybody else will be able to understand the dynamics of the DKA. Now it's time for questions and answers. So if you have a question, please put up your hand, and then we can call you and you can ask your questions. I think we'll take like 4 questions now. What's the time? Yes, we still have time. So we'll take like 4 questions, and after she has finished with that question, we still have time, we'll take some more. So we're waiting for the questions. Or you can put it in the chat. If you don't want to put up your hand, You can type your questions in the chat. We'll also read it out. Okay, there's a comment. Okay, I think that's just by Dr. Elitu. Yes. Yeah. Dr. Sholari, you have the floor. Please ask your question. Then Dr. Kudaya after Dr. Sholari. Dr. Sholari, please unmute yourself. You're muted already. Please ask your question. Dr. Sholari, we cannot hear you. If your service is not, can you put it into the chat? Dr. Sholari, can you put your question into the chat? We cannot hear you, please, if you don't mind. Thank you. Just put it into the chat, we'll read it out.
My question is this: your first bolus of normal saline, in anticipation of a CV, you can't hear me? Hello?
So we can hear you, but not too clearly, so we're requesting if your question, please put it into the chat because we cannot hear you clearly, Dr. Sholari. Thank you so much. Dr. Kudaya, your question, please. While I'm trying to.
Good afternoon. Thank you very much for the presentation. My question relates to subcutaneous administration of insulin. I know there have been studies that say we can use subcute, but what I'd like to know is, is it part of what ISPAD guidelines say we should do now, or is it for the low and middle income, countries where, the resources are not always available and the manpower? In other words, if I saw a patient with DKA and it's mild or moderate, can I still use my IV? Or should I use subcute? Thank you.
Dr. Sholari, we are yet to see your questions, but I will read one more question and then you can answer the two. This is a question from Dr. Onifade. Thank you for a very lucid presentation. I have 3 practical questions. At what point do you introduce glucose into the IV fluid? 1. 2, when do you switch from IV insulin to subcute in severe DKA? And would routine urine dipstick be helpful in early diagnosis? Those are the 3 questions. That makes 4, so please answer these 4 questions.
Dr. Onifade, I may need to come back to ask for a repeat of 2 of the questions, but in the meantime, I will go on. I didn't hear Dr. Sholari very well, but I know that she was asking a question about the first bolus. So I will attempt to preempt her that first bolus is given at a dose of 10 to 20 ml per kg. That's per kilogram of the child's body weight. and it's given evenly over 1 hour. Given evenly over 1 hour. So after that has been done, then one reassesses the child, and if there is still dehydration, then you can repeat the bolus. You can repeat the bolus. Okay, so I hope that I have answered your question. Now, thank you, Dr. Kudaya, for the question. Yes, ISPAD advocates that in all cases, in fact, they advocate that routinely and in all cases of mild to moderate, then subcutaneous route of insulin should be used because it has been shown to be as effective as giving the intravenous fluid. So I have just given those examples to say why in our setting we should embrace the use of subcutaneous insulin because those problems are relevant in our setting. But yes, whether it is in Iran or in Brazil or in Israel or in Nigeria, then it is still relevant to use subcutaneous insulin in mild to moderate cases. Dr. Onifade, yes, thank you for the question. For when should glucose be introduced? Yes, so glucose should be introduced when the blood glucose is about 40 millimoles per liter. That is somewhere, we really put it somewhere between 250 and 300 milligrams per kg. And the reason is that you don't want the child to be hypoglycemic because hypoglycemic is more dramatic in causing damage to the child than even the hyperglycemia. And as I try to explain, in delivering insulin, you give the insulin to take care of the acidosis. You also give the insulin to take care of the hyperglycemia. But the effect that you see is first in the hyperglycemia. So you will see that once you start to administer insulin, hyperglycemia begins to resolve, almost immediately. But you know that that is not the end. You also want to reverse the acidosis, and that takes about 48 hours. So you will continue to give insulin to reverse the acidosis. But one of the side effects of administering the insulin is hypoglycemia. So you want the child to have enough glucose. You want the insulin to have enough glucose to work on while the acidosis or the DKA is being resolved. Urine dipstick, ketone bodies, yes, that's one of the things that we use. The third criteria, I mentioned the ISPAD criteria in the diagnosis of DKA, the first being hyperglycemia, the second being metabolic acidosis, and the third being the presence of ketone bodies, either in blood or in urine. So urine dipstick can be used. So I got those questions. I am sure I missed one or two other questions from Dr. Mika.
Okay, thank you, Dr. Akinola. There's another question for you. When do you commence the subcut insulin in DKA management by Dr. Arod Shodipo?
Okay, what I have been trying to advocate is the use of subcutaneous insulin in mild to moderate DKA. But maybe I should try, maybe what you are trying to ask is, when should you go on to give insulin? When should you assume that DKA is resolved, and then when can you resume giving insulin? Because this child is going to need insulin on the long term, not just for DKA, but for the management of diabetes. And you comment that when the child DKA has resolved. So there are various insulins that you can use to do this, depending on what is available and the expertise of the physician administering it. So you can do pre-mixed insulin, you can use intermediate insulin, but I think, Professor Oduwole, we are advocating the basal bolus insulin. So that's what we are really advocating. So I'm not sure if I have answered your question. But that's what I think you're asking me.
Sorry, can I jump in?
I was just going to call you to ask your questions.
Apologies to everyone for jumping in like that. Good afternoon, everyone. And Professor Duale, lovely to see you. And Dr. Akinola, thank you for your presentation. What I really meant was that when you're managing your DKA and you want to use subcutaneous insulin rather than IV, when do you commence?
Okay, in the second hour. In the second hour. So you rehydrate in the first hour, because if you start the insulin, okay.
No, don't worry about that. I know that.
Okay, all right. So in the second hour, yes, in the second hour.
After you've given your fluid for the first hour, yeah?
Yes, yes.
Okay, thank you. And can I just ask my second question since I'm here? I know probably in your setting, subcut may be more appropriate in some scenarios for mild to moderate. Here we follow the BSPD. Obviously we're mindful of the ISPAD guidelines. And it's basically just IV. So maybe in a different setting, it might be appropriate. So I can't say they've got some good results and so on. So obviously it's worth trying. My first line will always be IV. But I can appreciate subcut may be useful. And the other thing is one has to be also mindful. You're giving a little child a jab every 2 hours. You also have to consider that. Is that really appropriate for the child? Unless you don't have a line, and then you can use that way. Just my opinion. I was just looking at the trauma to the child. This is a child who's going to be getting jabs pretty much the rest of their life. So you don't want the first few hours to be traumatic if you can help it. Thank you.
Thank you, Ma. I appreciate your concern. I just want to, because many people may also be wondering, you're giving this jab every 2 hours. I just want to make a little distinction between subcutaneous administration and intramuscular. Intramuscular administration is much more painful, but subcutaneous is not as painful as intramuscular administration. And when the mode of delivery is with the pen, which has very fine needles, especially in the case of children, rather than with the insulin needles, then the process is actually much less painful. I know that pediatricians are very careful and we don't want to cut the children any more than they are already hurt, but I think that the insulin pen go a long way in making them much more comfortable than they would have been if all we had was the insulin injection. Thank you, ma'am.
All right. Thank you.
Can I come to the Dr. Akinola's rescue? We still follow the ISPAD guideline. As much as possible, we give IV. And IV, but what she's advocating is if a patient comes to your clinic and the child has raised blood glucose and you're worried and you cannot get in touch with a pediatric endocrinologist, and I remember that she pointed out there that please don't start treatment, get a pediatric endocrinologist or a pediatrician that is well versed in managing a diabetic patient to please go along with you. Especially if you are not sure of your nursing staff to be able to maintain your IV infusion, because we've had cases where the infusion has been increased inadvertently, either because the staff did not understand how to adjust the doses. And so sometimes that can be a little bit dicey. So what she's trying to put across with this is that is not the standard. ISPAD is the standard. You keep saying IV, and we all know that the best result is when you give the IV. But if you're in a situation where you don't have a good nursing staff, or where you're not sure that this patient, you can transfer this child to another center where the patient can be put on the IV, then to do the child a lot of good if you start with the subcutaneous insulin. And then you can now transfer the child with ease, knowing fully well that this child, you have taken the child through the most difficult aspect of managing the decay. I think that's what we're trying to do here, so that people will not be afraid. You are in the night. We've had people calling us in the night. So what we're saying that this is nighttime, you cannot do much, but if you call me, I think I will confidently tell you to start subcute, and then in the following morning, please send the patient to where you are sure. That's what she's trying to put across. So
Thank you,
Dr. Shodipo, I hope we have satisfied. I know why you are.
Oh, sorry. Thank you very much for the excellent. It was not to criticize in any way. I'm sorry if it came out like that.
Okay.
But I know even here, I've had children that I've had to put on subcut, obviously in the mild, very mild DKA. So we've had to do that. But for as long as there's a protocol in place, and then we can have that going on. Yeah, thank you.
Thank you. Dr. Egejuru. Dr. Egejuru, you can unmute yourself, please. Dr. Egejuru.
Hello, can you hear me now? Can everybody hear me?
Yes, please.
Yes, we can.
Hello? Hello?
We can. Please ask your question.
Okay, I just want to make sure everybody's on. Okay, we're talking about diabetic ketoacidosis, and I'm not a diabetologist and I'm not an endocrinologist, but principles to come first. Number one, the insulin deficiency has been there for a while before we have DKA, right? The insulin deficiency has been there. But what the DKA we are dealing with now is a metabolic problem with dehydration. So I think that we should go by principles, replacing the fluids, correcting the metabolic acidosis, and making sure urinary output is adequate, 1 ml per kilogram body weight per hour. Then we can start talking about insulin management, because the insulin problem had been there before DKA. The child is presenting acutely because of the diabetic ketoacidosis, which is a metabolic problem. So I think we should treat everything, but we should start with correcting the metabolic problem and the fluid and electrolyte imbalance. Then the insulin therapy will start making meanings to me. I hope I am right.
Thank you very much, sir.
Rehydrate the child to the extent you think, do the electrolyte urea, whatever, correct the electrolyte imbalance, the potassium, the whatever. Take care of the cerebral edema if you can. Then start thinking about the insulin, whether it's subcute or intravenous or intramuscular, and then monitor the blood sugar as it comes down. Because sometimes from one's experience, people have told me that doctor gave me insulin and I almost passed out. Right? 50%. Please, I need to be corrected if I'm wrong.
Thank you, sir. Thank you, sir. You are not wrong at all. First things first. And before we went on to talk about the insulin therapy, we did lay a background of the principles, one after the other. So yes, the principles must be in place. Yes, the child must start to get corrected first. But the reality is that we need to be doing so many things at the same time after the initial resuscitation. So that's the practical setting of what happens when we are managing decay. But yes, first things first, ensure that the child is has, one start to correct the shock, address the shock, and then at least give the first shot, the first bolus in correcting the dehydration before starting all the other things, including the insulin therapy. Thank you, sir. We're on the same page.
Can I add to that? Yes, there's something I need to correct because it was talking about correcting the acidosis. Actual fact, in most cases, you don't need to correct the acidosis because when you give enough fluid, the acid would have been converted to bicarbonate. So bicarbonate is something we hardly use in the management of DKA. To use bicarbonate, your bicarbonate level should be at least 10 or less. If it's still reading 14, you don't do any correction. You just make, that means you're not giving enough fluid. Like I always tell everyone, what will kill this patient is not the lack of insulin, is the dehydration. So the first thing to do, as Dr. Akinola has been mentioning, and she said it several times, is to give your fluid. Sometimes you have to give a bolus like 2-3 times before you can actually see that this patient is better dehydrated than it is. Managing DKA, whether mild, moderate, or severe, needs a lot of experience and knowledge. And please, it's fluid first, as she had said, 10 mils. To most of the time now, we even say just 10 mils boluses because we don't want to do 20 mils. We are trying as much as possible to make sure we don't have cerebral edema. If cerebral edema kicks in, the possibility that that child will make it becomes very, very low. So we give 10 mils per kg, first bolus, 1 hour. The next bolus is usually about 2 hours. And by the time you've done that, 10, 20, that comes to 20, you'll find that the child is better hydrated. Then you can start thinking of giving your insulin. And then you can now move forward. I think there's a question by when do you change, that was by Dr. Nifade that you have not spoken. When do you, at what level of blood glucose do you now add your glucose to your IV fluid?
That has been taken care of.
You have, okay.
Yes. Yes.
Is there any other question, please? Any other need for clarification? There's something here that you spread your guideline protocol to everyone. We will. And then we're also using this as an opportunity to say we have what we call diabetes in practice. And we actually would like a lot of our colleagues to please come in for this diabetes in practice. And by the time you've gone through the 3 or 4 modules, I think the confidence that Dr. Akinola is trying to inbuilt into all of us will be there. If there's no other question, I think I will hand over to Dr. Letu for the closing remark and the vote of thanks, I think. Dr. Letu.
Thank you very much, ma'am. I want to thank Dr. Akinola for rising to the occasion, even though we are giving you a long rope, but at least you utilize your rope very well. Thank you very much. And be rest assured, we'll definitely be knocking on your door again very soon, and we hope you will oblige us. Before I hand over to Dr. Ije for vote of thanks, I would like Dr. Mobolaji Lawal. Do you have any comments, sir?
Well, thank you very much. I'm sorry my video is not on because I'm having bandwidth issues. So yeah, I think it's been a very informative session. I just join you in thanking Professor Duole for ably chairing the meeting and Dr. Akinola. Obviously, because DKA is relatively uncommon in general practice pediatrics, the protocol that has been mentioned is very important. And I do not advise that any general pediatrician who has not acquired the necessary experience and skills should attempt to manage, because you just don't see enough on a regular basis. So that protocol, I would recommend that each center should have it. I will be interested in having one. And also the use of routine dipstick in our environment, routine urinalysis on every child that is ill or admitted. Because of the way DKA presents sometimes, you may find out that it is the nurses that will diagnose, that will see ketones and in the sugar and ketones in the glucose and ketones in the urine and call your attention to it. And then you will find yourself diagnosing DKA from, routine urinalysis. So I would also add my voice to say that routine dipstick or urinalysis is a tool that the general pediatrician in private practice may want to adopt on all ill patients that have been admitted. Thank you very much, everyone. Over to you, Dr. Litu.
Thank you very much, sir. Dr. Ej.
Before Dr. Ej, because Dr. Bolaji Lawal mentioned something. Yes, dipstick is good, but let's don't forget that we have a threshold, and that by the time you are finding glucose in your urine, the glucose is extremely high. That means that child has gone from mild to moderate. So the advocate is, as much as possible, every hospital should have a glucometer and reagent strips. It doesn't take anything just to test the blood glucose of every child that comes into the hospital. I think there's something by the former Minister of Health, Professor, not the present one, where he said every child that comes into your emergency room or into your clinic with fever and what looks like sepsis should have the blood glucose done. And doing that, you may be able to discover more cases of diabetes than just doing your dipsticks. So before you start having ketones, 2+, 3+, that child is no longer mild, it's going to moderate. But the blood glucose will be the best. So my advocacy to all my colleagues, wherever they are, is that please, let's have glucometer in our clinics, in our emergency room. Thank you.
Thank you very much, ma'am. Dr. Akinola.
Yes, thank you. Good afternoon. Good afternoon, everyone. I would like to thank the organizers for putting this program together. It's been very informative. Thank you, Dr. Akinola, for a very lucid presentation and making something that would have made for a very scary call for most people a bit more simplified, showing us the boundaries that we should remember and how to, when to refer early. Obviously, we are not expected, if we don't know about it, to treat this from beginning to end. Thank you. Professor Duole, thank you. This is a fruit of your labor that we are enjoying today. It's nice to see 2 generations of pediatric endocrinologists in the same meeting. Thank you, it's a privilege. For everyone who took out time to stay from the beginning to the end, we thank you. For those who were able to join us for part of the way, but were called away by duty, we still thank you. There wouldn't be a meeting if people didn't attend. And for our elders, Professor Adenike Grange in particular, we thank you. You're always prompt, and it's support in itself that you join these meetings all the time. Thank you so very much, ma. And I wish you all a very pleasant evening.
Thank you very much, Dr. Akinola. And to also specially thank Dr. Idoko. He joined us very early as well. And please, let's remember that the next meeting will be on the 31st of March. And it will be a topic most of us, I'm sure as pediatricians, whenever we see cases, we'll just say refer. So I'm sure we'll have an interesting time on the 31st of March. Thank you. God bless you all. Bye.
Thank you, everyone. Bye-bye.
Thank you.
Thank
you.
Bye.
I thank you, Dr. Akinola. Thank you,
Thank you,
Professor
sir.
Duwa.